everyone, and thank you for attending our Orthopedic Movie Night series. We host these about every quarter, every 3 to 4 months. We have these, and they feature a variety of orthopedic topics. Our stars of the show are our orthopedic surgeons from Wisconsin River Orthopedics, and it is presented by Wisconsin River Orthopedic, or Aspirus Riverview Joint Center. Our speaker tonight is Dr. Frank Walter, and he is going to be discussing shoulder pain and treatment options. My name is Cindy Sullivan. I am the Joint Care Coordinator for Aspirus Riverview Joint Center. So my role with all of the joint replacement patients is to meet with each and every patient before surgery, during their hospital stay, and then I follow up with them after surgery. And what I do is coordinate their care and get them ready for surgery, do a lot of education beforehand, so they have all the proper equipment, everything that they need before surgery. And then while they're here in the hospital, I meet with them, do a lot of education, do discharge class with them, and then follow up at home as well. Our joint program is a team of individuals. We have our awesome orthopedic surgeons. We also have specially trained nursing staff, physical therapists, occupational therapists, surgery people, and we are a group that does this every week. So we are very well versed in what we need to do to make people successful when they go home. We know exactly what all of our surgeons want and how they want us to teach patients to be successful at home. Our Joint Center program has been very successful. We average about 325 joint replacements every year, and that includes knee replacements, hip replacements, and shoulder replacements. Rapid recovery for all of our patients, about 98%, do go to their own home versus going to a nursing home. We are the top 10 of all Wisconsin hospitals for surgical safety. We're ranked number 1 in Wisconsin for many of our outcome metrics. We have 0% hospital complications. We do exceed the national average in walking distance and knee range of motion. So for any of you that would have a knee replacement or a hip replacement, we record all of that, the walking distance, your knee range of motion, in a database that we share with everyone nationally. So we do exceed the national average on those outcomes. We are below the national average for surgical site infections and readmissions to the hospital. So very proud of our Joint Center program. It has been very successful due to the excellent team that we have in place. This next slide, I always like to show this, a picture of Wisconsin obviously, and all the little dots show where patients have come from to have surgery with us. So as you can see, they're kind of scattered about. So we've had people travel a long distance to come here just to have surgery here. We have also had patients come from the Chicago area and Minneapolis area as well. And it's not just 1 or 2, it is numerous patients that have traveled that far to come here. So we're very proud. Our patients have recommended us to their friends and family members. So again, has been very successful. So our goal with our Joint Center is to get your life back. We want to get all of you back to the things that you enjoyed doing prior to all of this pain. Joint pain, stiffness, a decrease in motion are not symptoms that you need to live with. So if you have your shoulder replaced, things that you're going to be able to do afterwards, once you're fully recovered, you'll be able to golf, walk, bicycle, swim, any of those things you can do once you're recovered. So our goal again is to get you back to all of those things that you enjoyed. So when your pain, stiffness, swelling limits joint movement and is persistent or unusual, we want you to see an orthopedic specialist. And with them, you'll start with the correct diagnosis. They'll ask you a lot of questions, and then make their decision and recommend treatment options for you. And Dr. Walter is going to discuss a lot of that tonight with you as well. Now, if any of you are interested in setting up an appointment with Dr. Walter or any of our orthopedic surgeons, I do have a nice little pamphlet in the back of the room, and it's called A Guide to an Orthopedic Specialist Evaluation. And what it does, it has a list of questions in there that your orthopedic specialist will ask you at that initial appointment. It also has questions that you can ask that specialist. So when you go to the appointment, you're very well prepared and you get the answers that you're looking for. So please, on your way out, if you're interested in one of those, grab them because they're very helpful to prepare for that first appointment. Next, I'd like to talk about Dr. Walter a little bit. He attended the Medical College of Wisconsin. He completed orthopedic surgery residency at Wayne State University, Detroit Medical Center in Warren, Michigan. He also completed an orthopedic surgery fellowship at the Medical College of Wisconsin for hand and upper extremity. He is board certified with the American Board of Orthopedic Surgeons and has additional qualification in hand surgery. He is a member of the American Medical Association, the American Association of Orthopedic Surgeons, the American Society for Surgery of the Hand, and the Wisconsin Orthopedic Society. Dr. Walter's goal with all of his patients is to get them back to an active lifestyle with as little pain as possible. Dr. Walter is here to return that happy smile to your face. So welcome, Dr. Walter. Thank you for coming in.
Thank you for the introduction. Thanks everyone for being here. Well, I want to thank everyone for taking the time out of their day to come tonight. Hopefully we can make this educational and maybe a little entertaining. I don't promise any entertainment. It's like my grandpa used to tell me when he'd take me fishing when I was 10 years old. He could see the look in my eyes. He knew what I wanted. I wanted to catch fish. But what he really said was, son, I'm going to guarantee you a boat ride. I don't promise any fish. Right? So I guarantee you some education tonight. I don't promise any entertainment, but we'll see what we can get. Cindy, I appreciate the introduction. She went over my kind of boring history, but I thought this is interesting to tell you a little bit about who I am and where I'm from. This is where I started in Southern California. I was a California boy. If my dad hadn't moved us to Northern Illinois when I was 11 years old, I'd probably be on a beach right now surfing with my cousins and having fun. And I don't know, maybe that would be fun too, but I like what I'm doing now. Once I was in Illinois, I ended up going from there to South Carolina, then from South Carolina up to North Dakota, where I ended up graduating from undergraduate school. And then after that, I made a brief stop in Illinois before my dad said, you need to get out of the house. Went back to North Carolina, eventually back to North Dakota, back to Milwaukee for medical school, then over to Detroit for my residency, back to Milwaukee for fellowship, and then from there I've kind of stuck around in Wisconsin, been up in Eau Claire for a couple of years, down in Portage for the last 10 years, and now here in Rapids. So I've been all over the place, and what this leads most people around here to ask anyhow is, who are your teams? Who do you root for? As a California guy, but you should know my dad was from North Dakota, and his dad grew up right across from Wrigley Field, so I have this Chicago influence. So I don't want you to think I'm a bad guy because of it. The Cubs are really the one team I root for the most, but when the Brewers and Cubs are playing, honestly, I don't care who wins. They're both so fun to watch. My son has become a huge Brewers fan because he's a Wisconsin guy, and yes, watching the Packers win makes my patients happy, makes my wife happy, so therefore I'm happy. Education, I think Cindy went over this in detail. It's kind of taken me all over the country. So, by way of introduction, when I talked about what we're going to talk about tonight in shoulder pain, it's a big topic, and we can talk about many different things along the way. But the most common thing that I see is rotator cuff problems. And I thought this slide was interesting to me because these are all things that people have referred to the rotator cuff as, and these are all terms you can Google on the internet. And you know, to us it seems kind of silly because we know what it is, but to the general population, we don't know what this is. So by the time we're done tonight, I want everyone to know that a rotator cuff is not these things. It's a rotator cuff, and we're going to talk about what it is. If we start talking about pain, people describe it as impingement or bursitis or tendonitis, partial tears or complete tears. It creates a lot of disorientation and bewilderment at times. We're going to try and clarify that tonight so that when you leave here tonight, you'll have a basic understanding of how a rotator cuff works. So, objectives. We're going to talk about the anatomy of the shoulder, the pathology that's involved, the things that can go wrong. The natural history is what happens to a shoulder if life just goes on and you never get injured, right? Because it does wear out just like most parts in our body. And what some treatment options are and how those outcomes, and really try to clear up the confusion as to what the cuff is. So first of all, what do we use our shoulder for? Simone Biles, she uses it to do handstands and all kinds of crazy stuff. Tiger Woods, back in his day, hit a golf ball. Look at the rotation on this guy's shoulder, throwing a baseball 100 miles an hour. More around here, hunting and fishing and chopping wood. This is a picture of me. My wife didn't think I should put this in here, but I thought it was really important for you guys to know. Anyhow. So, bones of the shoulder, basic stuff. Scapula, more commonly referred to as the shoulder blade, is a very complex bone that has a number of different joint surfaces. One of them here, commonly referred to as the socket, joins up with the ball, the head of the humerus here. The other part of the shoulder blade meets up with your collarbone up at the top, and this can also be a source of pain. We look at it on an x-ray, kind of straightforward, normal x-ray where the ball and the socket are meeting together. As an aside, when arthritis kicks in, you know, we all know what bone on bone looks like in a knee x-ray. I think when my patients see that, and some people might even feel that right now in their own knees. But on a shoulder, we see the same thing. We see bone rubbing on bone. This is kind of early arthritis. There's an extra little bone down here, and this space is getting a little smaller. But because we don't walk on our hands like Simone Biles does all day, right? Our shoulders can go a lot longer with that bone on bone than our knees and hips can. MRIs are a very common way to look at shoulders, and I thought this is a good way to just start the conversation about what goes wrong with shoulders. We can see our ball and our socket right here. And on the top, we see this muscle. This muscle is called the supraspinatus. It's part of the rotator cuff. And it comes over and it attaches onto the bone. You can see the transition where it goes from a little gray to more black. The black tissue is actually the healthy tissue. That's good, normal tissue. On this side, we see this glaring white hole here. And that's where the tear occurs in a rotator cuff. As the talk goes on, we'll talk a little bit more about what that looks like in real life and how that affects our shoulders. Ultrasound is also another way, and I use this as another segue to say there are some people who just can't get MRIs. Either they're just too claustrophobic, they have a pacemaker, they have metal in their eyes or their brain that prohibits them from being anywhere near the big magnet. Sometimes we just need a quick answer to the problem, and an ultrasound can be done in the office. I do those all the time. And honestly, it's a lot more comfortable. And on an ultrasound, we get a little grainier picture, but we can still see where there's tissue here, and there's a hole right here, that black hole. So that's another opportunity. Rotator cuff is made up of 4 muscles that come off of our shoulder blade, right? So remember that picture of the bone. Now it's covered with muscle. And the red muscle turns into white tendon. For any deer hunters out there, I think you've seen this before. You know, this is the part we like to eat. This is the part we don't like to eat because it's thick and tough. But it really covers the ball all the way. And this picture down here kind of shows it nice. The ball's normally like this, but this cuff has been peeled back. It literally covers the top of it. And so you can have a hole in one little tiny portion of the rotator cuff down here, and the rest of it can still work. So patients ask me all the time, how is it that I have a rotator cuff tear but I can still raise my arm, right? Because you've got probably 40 millimeters or, you know, 1.5 inches, almost 2 inches of rotator cuff from the front to the back, and sometimes only as little as 6 millimeters or 1/4 inch of that is torn. So if the rest of it is okay, then you can still raise your arm. And we'll talk more about that as time goes on. The primary function of the rotator cuff is to really stabilize the ball within the socket. And this is something that we figured out over the years as we watch people get injured and watch people rehab the shoulder. We know that if the rotator cuff is torn in one spot and we strengthen the other spots to keep the ball sucked into the socket, that a patient can still raise their arm. So there might be people in here, folks in here, who at one point in time in their life have had problems with their rotator cuff or their shoulder, and they've done a little therapy, right, to strengthen it, and now the pain goes away. And it's because this rotator cuff right here, this muscle, has a little layer called the bursa, this blue stuff. This blue stuff is a cushion that protects the ball, which is underneath here, from the top of the shoulder blade here. And when that cushion is gone because the rotator cuff is torn and pulled back, then the bone can bump into the bone. And that's where people get this pain when they get into this, often this position here, or reaching behind their back is another common way for this to start hurting. So once that tear happens, we need to do something to fix it. Here's another schematic of how that works, showing that you have two opposing forces. This one red arrow going here pulling down is the rotator cuff, and the other going up is our muscle called the deltoid. There's our big bulky shoulder muscle on the outside. That deltoid is constantly pulling up, and the rotator cuff is constantly pulling down. When they're in perfect balance, the shoulder rotates and moves very nicely. But when the rotator cuff becomes weak, the deltoid overpulls, and then you end up getting this pinching again between the top of the ball and the bottom of the roof here, this bone called the acromion. And this is what it looks like. Again, this slide didn't turn out the way I wanted to, but you kind of get the idea that as this goes up, the outside part of the bone bumps into here. There's just not enough space. When I talk to mechanics know about, and machinists, they know about this term called tolerance, which many of you probably understand. That there's tolerance. There's a couple millimeters one way or the other where the part will still fit together. In our shoulder, the tolerance is probably only about 8 millimeters. So if anything changes that space, right, makes it smaller, you start getting pinching and pain. So it's a really tight space. The crux of it is, the unfortunate thing, is that the most common position to have our arms in to work, elevated about 40 to 60 degrees and turned in a little bit, right, like this is where it puts most stress on the rotator cuff, right in this spot, and it also happens to be the area where the blood supply is the worst, right? With the blood supply being the worst, it has a very poor capacity to heal itself. Whereas in our bodies, our liver has a great capacity to heal itself. You know, so if you go to a wedding next Saturday night and have a few too many champagnes, your liver will heal itself overnight. But your rotator cuff can't do that because it can't get the blood supply to that area fast enough. I'm not sure why God designed it this way other than to give me a job, which I'm happy about, but at the same time, it's something as simple as if you have to work in this position, getting on a step stool so that you can work down here can actually save your shoulder. And these are things that big companies are figuring out all over the place. The post office has not figured this out yet, neither does UPS, right? So we take care of a lot of those patients who are constantly working all day long up in this position. So how does a shoulder go bad or a rotator cuff go bad? Well, trauma, so car accidents, falls, common things. I find a lot of people they're torquing a wrench and it slips and it gives way, right? Or they're lifting something up overhead and they have to give it that last little push and they feel a pop in their shoulder, right? It's part of the rotator cuff goes bad as part of the aging process. You know, like my 10-year-old says, he says, "Dad, I'm literally getting older every second." This kid's got some problems on the line. Maybe he's at 10 he's a little dramatic, but the point is true. I mean, the parts are going to wear out as we go on with life. But don't worry, somewhere in here I'm going to show you the secret how to protect all this. So patients with no pain and have rotator cuff tears at increasing rates with increasing age. What that means, if I take a sample of people age 50 to 80 who have no pain in their shoulder and I do an MRI in them, at least 50% of those people will have a rotator cuff tear, just like the MRI I showed you at the beginning of the talk. And yet they have no pain. They have no idea they've got this tear in their shoulder. Why is that? Well, because their other muscles have compensated. The rest of that cuff is strong enough that it's compensated for that hole in the rotator cuff. So if you unfortunately become one of these people who has pain in your shoulder, I might very well tell you the first thing to do is to go to therapy, right? Go to our therapist, go to Cindy, right? And get that cuff strengthened up. And go to Faith too, right? So, and then we try not to use our shoulders in a bad position. Again, this position all day long, right, or even up here, can really wear the cuff out a lot quicker. So again, why does it go bad? Injury. Patterns develop in how we use your arm. Another common question I get in the office is, doctor, my shoulder's been fine forever. Why did it all of a sudden start hurting? I didn't do anything different, right? Well, that's kind of the point. You did the same thing for 10, 20, 30, 40 years, and finally your body failed to compensate for it. It's like that one last grain of sand that tipped the scale in the wrong direction. This is a very common phenomenon in orthopedics as well. So we know that when this happens, we get this imbalance that we talked about. The imbalance leads to weakness, and then that impingement, and then, oops, I'm going backwards. And then attritional tears or just wearing out can help contribute to this imbalance. A lot of times what we get is a patient in their 50s, 60s, 70s, and their rotator cuff has been fine for years, and then all of a sudden, one thing happens. It goes from completely normal to can't raise their arm at all because it hurts so bad. And that's when people are really puzzled, like, how did this happen, one little injury? Well, it's probably because that rotator cuff was pretty worn out already, right? And then when that one pop happened, that one thing, and then it tore a bunch of tissue off. And we've got a slide here that illustrates that as well. So again, one of the primary functions of the shoulder is compromised. Other parts of the system can compensate and give it normal function. This is kind of the secret. If we could figure out how to train everybody's shoulder to function even with a tear in it, we wouldn't need to do surgery on people anymore. If these systems are not strong enough, then an imbalance occurs. The imbalance leads to pain and dysfunction. And this is really important. Therapy is the cure for most patients with an imbalance. It's probably 80–85% of patients that I see will respond to therapy, leaving 10 or 15% of patients who end up needing surgery. One more slide to illustrate this compression. And I think this really shows it well, how the center of the ball is way up here and the center of the socket is way down here. Nobody who designs an engine would design a ball and socket to be that far off balance. It wouldn't work, right? But this is what happens when it wears out. And that's why when we get into these positions here, out in front of us, that causes that pinching. And that causes pain. So here's the cycle that we talk about. We get an imbalance in muscle, you stop using your shoulder as much, you get more weakness. Weakness leads to impingement. Impingement leads to pain. You use it less and the cycle continues. So, again, how to recognize a tear, pain. I think the most common thing, people come to me and they say, it hurts right here, right along the side of their arm here. And oftentimes in the front, but this is really common. I had one patient who used to rub her arm so much here, she gave herself a bruise. And once we fixed her rotator cuff, the bruise went away. She couldn't believe it. It had been there for 10 years. And that's just a kind of an oddity of the shoulder here. The pain can go up into the neck or down the arm. It often is described as a dull toothache. It's sore sometimes when you roll on it. Try to sleep on that side, it hurts. But other times when you sleep on the other side, it hurts just as bad because it's pulling across. We haven't really figured out the correct position to get people in for everybody. So everyone I just tell to find a spot that is comfortable. But sleeping is oftentimes one of the worst symptoms of rotator cuff problems. And again, worse with overhead motion or reaching behind the back. And the shoulder gives out. It gets tired really fast when you've got a rotator cuff problem. And that leads to more issues down the line. So again, another picture showing that tear in the rotator cuff. Okay? And on the ultrasound, that black hole that we don't like to see. An x-ray showing again what happens is the center of the ball gets elevated relative to the center of the socket. And you can almost see that impingement, right? It's about to happen. As soon as this person goes to raise their arm, this bone here is going to bump right into here. And that's a problem. This usually happens in the very late stages of rotator cuff problems when someone has had a tear for years and years and years. And as an aside, often these people end up with shoulder replacements, which is a talk for a whole other day. So again, who gets rotator cuff tears? Traumatic injuries, usually falls, car accidents, sudden jolts or lifting, usually feel like there's some sort of pop. They get immediate pain and can't raise their arm. It's almost like a broken bone, right? And we treat them that way. We try to fix them as soon as we can. But these are probably 20% of rotator cuff problems, and this non-traumatic, this slow onset of pain that develops over years and years and years is probably 80% of the problem. So we talk about natural history, and again, this is a repeat of something we already said before. It's important to note that if I took an MRI of everyone in this room, that well over half of you would have a rotator cuff tear, even if all of you said you had no pain. It sounds awful, right? But if you don't have any pain, you don't need anything done. If you don't have any limitations, there's nothing to do. But I'm going to show you the secret in a few seconds here on how to prevent this pain from coming on. We really don't know what causes some patients to have pain and others to not. We haven't figured this out completely, so it's an opportunity. But we know there's a consistent decrease in the strength of the rotator cuff as the size of the tear gets bigger, right? So as we get older and use our cuff less, we know that the strength of the tissue gets less and less. And this leads us to make different decisions as we go to fix things. So here's a guy with an acute rotator cuff tear. That's as high as he can raise his arm. That's a big, strong guy. He was an iron worker. Can't raise it any higher. Again, non-traumatic tears, you have a slow onset of pain and disability, typically no history of injury. This is what I want to highlight right here. 80 to 90% of these patients can get better with therapy in conjunction with home exercises. Right? So when you go to the therapist, they're going to give you some exercises to do. You do those exercises, and most of the time it works. Has anyone here ever had a cortisone injection? No one? Yeah, we got one brave soul. Do you want to come up, and I'm going to give you one so we can show everyone that it's okay?
I'm getting one tomorrow.
Oh dear, I'm sorry. I hope it goes well. So cortisone injections are something that orthopedic surgeons use a lot. We use them in knees and hips and shoulders and wrists and elbows because it helps. It doesn't help everybody, but at least half the people get completely better from a very innocuous intervention that's very safe. So if your surgeon recommends something like that, it's often something to consider. And we'll talk about how that works in a minute. Time 3 to 6 months minimum to get better from all this stuff. And if all of this fails, then we start to consider surgery to fix this rotator cuff. But again, we try to weed out all the patients that are going to get better without it. If I had to operate on every patient with shoulder pain who came into my office, I would never see my family. I would never get home. Because 80% of these people get better without any surgery at all. Look at a happy person doing therapy, isn't it great? So this is really important. I'm a firm believer that physical therapists are professionals in their own right. They have extra training in a specific area of the body, and I think some people poo-poo therapy, say, oh, they can just tell me what to do, or I can look it up on the internet. That's not true. These people have a very distinct understanding of the anatomy that's different and sometimes more detailed than mine. And so I respect them very much as professionals in their own right, and I use them a lot. And they help my patients get better faster. Success, and that's how we get success rates in that 80 to 90% range. This here, internal and external rotation strengthening, seems to be the most important thing to restore the balance of the shoulder. And we're going to go over that in a few minutes. Here's a patient getting a cortisone injection. It looks awful, but look at how happy they are. I think if you've had people have had cortisone injections in other places, they oftentimes try to correlate that to how the shoulder is going to feel. I personally have found in 20 years of doing this that the shoulder is the most comfortable place to get a cortisone injection. Really? Yes. I think feet are the worst. I think knees are probably the next worst. Hips are usually okay. You know, but the shoulder's pretty well tolerated. 90% of my patients say, "Oh, you're done already?" I'm like, yeah, it's good. It feels like a little swelling, but it's not horrible. And honestly, it doesn't hurt me at all, so everybody's happy. Take a deep breath. Chance for any questions at the moment. It all makes sense. There is a quiz at the end, so if you want your free popcorn, you got to answer the question.
Over here.
Yes, sir.
What if our x-rays already show there isn't much in there, in between the ball and the up above here? Because
right, and that's a really good question.
this is my arm. That's as far
That's
as
what you got, yeah. And I think when you get a shoulder that's like that, we start talking about different options. There are some people who believe that therapy can bring that shoulder back to life. I have not seen that in my short time in this job, right? And then oftentimes shoulders like that end up with surgery if the patient is hurting bad enough or if they're limited enough, right? And a lot of people will ask me, you know, they say, "Doctor, I'm 80 years old, I'm too old to have surgery." I said, well, if you're 80 years old and you're living at home and you're taking care of yourself, I don't think that's true, you know, because the disability that's caused by a shoulder that only gets this high and has pain is big. It might mean the difference between being able to take care of a person on their own or needing 2 or 3 people to help them with everything they do. So there are options for stuff like that, but they typically involve replacements. And the replacements do really well, often better than rotator cuff repairs, which is something we can talk about kind of as an aside. Any other questions moving forward? So we talked about the difference between partial rotator cuff tears and full tears, okay? It gets to be a little confusing, but again, I want you to remember the idea that the rotator cuff is a tissue that is designed to wear out. It's going to get thinner as the time goes on. Just like if you're lucky enough to be able to wear the same pair of jeans for 20 years, because you stay in shape, right? You're going to wear a hole in those jeans in the knees somewhere along the way, right? And it's not going to have the same thickness to it. If you snag that on something, that little hole can become a big hole, okay? And that's how partial tears are kind of thought of. Full thickness tears, when it pulls completely off the bone, it'll never heal itself. It won't go back because it's constantly under tension. When it pulls off the bone, it literally pulls away and it can't go back on its own. It needs to be put back there by a human being. But partial tears can become stable in terms of pain, but they won't typically heal back down to the bone either. But again, if we can fix the rotator cuff on either side with therapy, then that partial tear can be compensated for. Unfortunately, in patients who aren't getting better with therapy, if you look at their shoulders a year later, about 90% of those partial tears are either the same size, bigger, or have gone on to full tears. And this I think is important, because if you get told you got a partial tear, it's more important than ever to start doing the exercises and the therapy to protect the rest of the cuff you have so that partial tear doesn't progress. So full and partial tears, this may be a little more than this talk needs to have, but the idea being the greater the force necessary to produce a tear, the better the tissue. So ideally, or the way we say that is that the younger you are, the more force it takes to tear the tissue, right? As in our 20s, an accident might break a bone instead of tear a rotator cuff, right? Because the rotator cuff is so strong. Whereas we get older, an injury might tear the rotator cuff because the rotator cuff is weaker. So the better the tissue, the better chance of success with surgery. That makes sense. So what to do now? So we've got a shoulder that hurts, right? So what do we do with it? Option one is always live with it, right? It's not a heart. It's not going to kill you to have pain in your shoulder, but it might slow you down a lot. So we can always talk about this. It's likely to get worse slowly over time if you do nothing, and it may result in permanent loss of function, again, if you do nothing, right? So option two, therapy, maybe cortisone injections, give it time. And I think this is always worth a try. I don't know why I put May in there. It's always worth a try to get this, try to get this better. But we always have to consider the person's age, their activity level, what their goals are. I can think of a gentleman that I took care of years ago, 65, barefoot water ski national champion. And he said, "Doc, I can move my arm and it doesn't hurt, but when I get on my skis, I got no strength." Right? Or on my feet, I should say, because he's barefoot. And I said, "Well, we'll give it a try." And sure enough, we fixed him, and 2 years later, he won again, which was great. But that's not the normal. The normal is a person who's got inability to raise their arm, they've got pain, they can't sleep, and those are the people that we end up fixing down the road with arthroscopic repair. The rehab is the thing that keeps a lot of people from going through this. The rehab for shoulder surgery is 3 to 6 months minimum, probably closer to 6 to 9 months, if you really want to talk about what it takes to get better. And that's for rotator cuff repairs. For things like shoulder replacements, it's probably half that. People usually get better a lot quicker. So, just kind of nuts and bolts of how we fix it. Here's a ball and a socket. Here's our rotator cuff. And what we do is we take it from pulled off the bone here, put it back on the bone, and then we use a construct of little plastic anchors. They look just like drywall anchors that have threads in them. And the threads are designed to go through the rotator cuff tissue, come over the top, and then on the side of the bone we plug them in. So the farther I push this one in, the more it pulls this tissue down. And what it does is it takes this cuff tissue, this yellow stuff, and compresses it down to the blue bone, right? The bone has all the blood in it. The blood brings all the supplies, right? And it creates a scar between the yellow and the blue here. And that scar is a healthy scar. So now the arm can work again. This is kind of what it looks like. Arthroscopic surgery is how I do this. There are other surgeons in my group who use little smaller incisions called a mini open. Both very reasonable ways to fix a rotator cuff. We use a camera inside the shoulder and we fill the shoulder up with water. So it kind of creates an underwater aquarium. It's, you know, blown up in, you know, high definition. It's kind of my favorite video game to play. It's really fun. You know, we've got these tools we can get around, and we can really get to some really tight spaces to fix, you know, something that's this big, right? It's that big, and the tear's only that big, and we can fix it. It's like my one assistant likened it to building a ship in a bottle. It's the same kind of idea. You got long instruments that get inside and allows us to do this, and it takes us. As I was preparing this, I gave this talk 12 years ago, and down here it said 2 to 2.5 hours. I thought this was kind of interesting. The more you do something, the better you get at it, right? Except for golf. We see people up in a chair like this. This video classically does not work, but the idea being this little metal instrument is a pincer. It's like a little grabber. And it's grabbing a chunk of rotator cuff tissue that's up here, this white stuff. And if in the video what you would see is as I pull it this way, the tissue actually has some resiliency, some bounce to it, and it comes out over here and goes over the bone. So this is the bone once it's been prepared, right? The anchors are going to go here, and a couple more over here, and that's going to compress the rotator cuff down to the bone. So, are we ready for the secret? I didn't even put any slides in here because I don't want the word to get out. I still have kids that put through college and 2 daughters that, you know, marry off and stuff like that. So I can't have everybody find out this. But the secret, in my opinion, and I was talking to Cindy and Faith about this at one other point, if we could teach everyone how to do these exercises, I think it would get rid of shoulder problems, 90% of it, right off the bat. And this is simple stuff. And we've got a little handout to give you to go along with this. It's something that I think if you did every day, just a little bit, and it doesn't take much, to strengthen the rotator cuff, then it would really help. It would really help. It helped prevent problems. So we'll show it to you in a second. Cindy's handing this out. Any more questions as we're handing this stuff out?
Well, I know you already said that
Yeah.
sometimes you have shoulder pain that can go down.
Yeah.
You have shoulder pain that goes all the way back to the shoulder blade.
Yeah,
as well.
it's all part of it, usually, yeah.
Okay.
I mean, it's important to note too that sometimes shoulder problems can look like neck problems, and neck problems can look like shoulder problems. And so it's not uncommon to have both at the same time, or to have a neck problem make it look like a shoulder problem, or a shoulder problem look like a neck problem. So that's where your surgeon can help you kind of sort this out. Sir?
I guess I was just thinking of a couple questions,
Yeah.
talking about this, the neck problem. So I've got a problem with the shoulder,
Yeah.
and I'm feeling something over here at the same time. Are they related, possibly, or?
Very, very possibly, right? Because when you get an issue, say you've got this impingement, right? All of a sudden you can't use your shoulder normally. When you can't use your shoulder normally, all the muscles, the 10 or 12 muscles around your shoulder blade that typically move it and hold it in place, they have to compensate and do different things. Well, that pulls on other muscles, right? So even the right shoulder can make the left neck sore if it's bad enough, right? And this, I think, is where my therapy team has a great leg up on me. They get their hands on you, they feel around, they can feel all the knots, they know where you're tight, and that's what they can do that I can't as well.
Okay.
So yeah.
Then along that same line, with this same shoulder issue, I was having pains in one direction. This morning when I woke up, the pain was completely different, and this, as Jack was saying, about how high he can raise his arms.
Yeah.
I find sitting in the car today when I want to go, at the bank to get to the teller,
Sure.
put the money in or whatever, I have a hell of a time getting up to the top so I can put my hand out the window.
Right.
It wasn't there yesterday, it was just fine.
Yeah.
That movement.
You-
But I had other movements yesterday.
Sure. And it sounds like you're kind of teetering on that edge of where your body's able to compensate, right? And maybe starting some of this strengthening stuff will fix that and rebalance it, right? Good question though, but I think that,
His question made
Okay.
me think of another question.
yeah, fire away.
Well, I had a massage once, and she said that my muscles here were so tight.
Sure.
Now, could this tight muscles would create a shoulder pain itself, or?
I think it's probably the other way around. I think the shoulder problem
pain
is
causing
contributing more to the
the
tight
tightness
muscles.
of the muscle.
More than likely.
Okay.
But again, it can all be interrelated, and I think that it's important for us to know and for you to know that everybody's different,
Right,
right?
Okay.
They're just that much different. There's very many things that are the same, but the way you use your shoulder, the way you use your shoulder is different than how I use it, right? And I think that's where we can start with one common exercise that we're going to show you in a second here, to get these shoulders strong. I think the easiest way to do this to start with is to just lube it in your hand with your elbows tucked to your side, right? And this is the really important part, is that the elbow has to be to the side. And this is a slow motion activity. It should take you about a minute to do 20 reps of this, just back and forth, just like that. And if you tuck your elbow in and force yourself to hold it in, it'll get sore faster than that. And just go nice and slow.
The other thing you want to do is take and pull the shoulder blades back and down.
Yeah,
So get
right.
them back and down and then do them.
Throw your chest out, right? We don't do that in America. I had a coach tell me this one time. He says, we don't, especially our young girls, we don't teach them to walk around like this, right? We teach them to walk around like this. And that posture thing that Faith brings up, I think, is really important. So this honestly, just like this, might be enough. If this is too easy, guess what? Now you got enough, double it up. And now you've made it twice as hard, okay? This will get the external rotation. For the internal rotation, we need like a doorknob or something. That can work one way. Now we put it on the doorknob, and now we're coming in. And really going slow and feeling that elbow tucked in here, and again, maintaining my good posture. Just like that, and that's the internal. And I would say, you know, sets of 20, 3 sets of 20 once a day. If you're not having any pain, if you're having pain, come see us first. We'll get you to therapy, and they'll get you a program that'll work. But I think if people did that as part of their daily routine, it would probably limit a lot of shoulder problems. That's my secret.
Would this be beneficial? I mean, like I said before,
Yeah.
our x-rays, I mean, the wife and I both,
Yeah.
I got both shoulders are shot.
Oh, sure.
And where the x-rays basically are showing nothing, no cartilage in there anymore.
Right. And I think what you're describing sounds like kind of the next level of when a shoulder goes bad. Because when the joints, where the ball and socket meet, when they start to wear out and you get arthritis in there, these exercises can help. But now you're moving a rough ball and a rough socket, and that really hurts. And that's when things kind of take a different turn, and we start talking more about surgical fixes to those problems. And the surgical fixes are very good, you know, but that's where you're at, it sounds like.
But now this says, but you're still not local surgery, you're a complete surgery, I mean, surgery, you're completely out of it.
Oh, yeah, for a shoulder replacement and for rotator cuff problems, we put people to sleep, yeah. And we numb the shoulder up, and it's very well tolerated. And it's something I'd be happy to talk to you about,
No.
yeah.
So, I mean, now to further inform us, if we wanted to progress from this meeting on,
Yeah.
to meet with, say, you,
Sure,
we would make the appointment, and you would come, look at our x-rays and so on,
Absolutely.
and have a discussion as to actually looking at the x-ray.
right, and we'll look at your shoulder and talk about your life and how it affects you, and it's a very personal thing, yeah, absolutely. We got spots, plenty of spots. What else? Yes, sir.
Do supplements like osteobiflex help?
Yes and no. I think that the science, the studies that have been done on these things are very few and far between. The companies that make the supplements don't usually sponsor the studies because they're afraid it'll show that it doesn't work. So they've done a couple randomized, what we call placebo studies, where they give one person a sugar pill and one person the actual pill. And it works about 50% of the time, maybe 60%. But I can tell you, I've met numerous patients who swear by it. And they say, if I take my chondroitin or my osteobioflex or whatever it is, if My pain is better. To that I say, great. It's not going to hurt you, right? And if it is what we call a placebo effect, more power to you. It's great. So short answer, I wouldn't spend a lot of extra money on it, right? But depending on what your issue is, it's not going to hurt you to try. I don't make money off of that. There are orthopedic surgeons who brand it, put their practice name on it, and sell it. Not us. Does anyone try that stuff? Anyone have success with the supplements like that? Not in this room. Yeah, sir.
Heat or ice make a difference?
Yes. In the early goings, if you have an injury, you know, you're doing some work in the yard and you feel it pop and it hurts, I think ice is best. Heat after an injury like that only accelerates the inflammatory process, and that can make the pain worse. But as we get stiffer shoulders, right, before we're going to exercise and use them, I think heat is a great way to warm up, and then ice for afterwards. Does that answer the question?
Sure.
I think it's safe either way, whatever works best for you, but typically heat before, ice after work.
So a local, like Aspirus, for instance.
Same thing. Not going to
If it
solve.
does, fine.
It's not going to solve the problem,
No.
Mhm.
right? The problem is the impingement, right?
Sure.
The problem is the tear creating the weakness and the imbalance. The exercises are going to solve the problem, but all these other things, the supplements, the ice, the heat, the Aspirus cream, are going to make the shoulder move better, right? So that you can do the exercises, and I think that's reasonable. That's the same reason we often give cortisone injections, to get people's shoulders moving better, so that when we send them to therapy, the therapist can actually do something with them, because it's not hurting as bad.
How
Yeah.
about the range of CBD oil?
Again, I wish I had a business that sold this stuff, because my gosh, there are people making money on it left and right. If you look at the list of things that CBD oil is now used for,
Yeah.
that should, to me, should make you raise an eyebrow and say, well, how can one thing be that good for so many different things? So again, if it helps you, great. I've got a lot of patients who have told me it helps them. But I don't recommend or not recommend it. I say it's your money, do what you want
Well,
with it.
yeah.
And it's not cheap.
Mm-mm.
Yeah,
Last spring, I was painting a room and I was trying to edge the top.
Yeah.
All of a sudden go,
yeah.
jerk it, I coming across. Is that rotator cuff or is that?
More than
something?
likely. Yeah, that's your rotator cuff with a subtle imbalance, subtle weakness that it can no longer stabilize the ball in the socket, right? So these exercises for 2 or 3 weeks and then ongoing can actually make a difference with that. Yeah, absolutely.
What about the competitor of, with laser treatment?
Laser for what?
Shoulders, knees, anything?
I would put the lasers in the same category as the CBD and the osteobioflex and all that stuff. No rigorous studies have been done to show that they make a difference. It's not something that we're taught in our training. It's something that other people have kind of tried to do here and there. And I don't know. I got a laser right here. Let's try it. Does it feel better? No. Well, if I told you for $120 an hour that it was supposed to feel better, you might buy it. Now, I say that tongue in cheek because I don't know. I've met a lot of really smart people in my life that I never would have thought could help my patients, and I would have been wrong, you know. So I think that we got to keep our eyes wide open when we talk about those things. As long as there's no potential harm, then it can't hurt to try. But this stuff I'm talking about is well studied, well documented in the literature for the last 100 years, and it makes a lot of sense. The laser, I don't know. If it sounds too good to be true, it probably is.
Well, I guess when we're chicken as far as surgery goes, I guess
Yeah.
that's where the situation.
And I think that's where the rubber hits the road for a lot of people. And these are things that when we sit in the office and we're talking one-on-one, we can really get into it and what it means for you and for you, you know, because we're all different. No one should be excited about surgery, especially what we call elective surgery. You know, everything's fine right now, but it hurts. Surgery tends to help, right? But you know, one of my wise mentors with all the gray hair and everything said, just remember, young man, there's nothing that surgery can't make worse, right? So we have great outcomes here with our total joints, and that's part, you know, that's a big part because we have a big system, and we carefully choose our patients, and our patients choose us, and we work together to make a plan. But even in the best case scenario, surgery can go bad. It can make things worse. Not common, but when it happens, it's really bad. So you're right to be wary of it, but I think we got options for you.
Where do these young ladies work then, here or at your place?
Cindy's here.
So our joint center is located second floor of the hospital, the tower area.
Oh.
So that's where we see all of our joint replacement patients.
What about the therapy over here?
At the Bethke Center,
Yeah,
that's all outpatient. So that's typically for people that are coming
Sure.
in for therapy to help their problem. It's also a place for people to go, like after your knee replacement, you have to do physical therapy 3 times a week or, you know, something like that. They'll go there for their outpatient therapy.
Good questions.
Mhm.
What else? Well, I want to thank you all for your time. I'll stick around for a few minutes if anyone has any questions they want to ask me one-on-one, that would be just fine.
I have one more question.
Yeah, you bet, man.
Should, I don't know, I'm speaking for myself
Yeah.
now, with the shoulder pain that I'm having, which I don't know which is causing the
Yeah.
shoulder pain, should I be doing these?
You bring up
exercises?
a really great point, and I should have mentioned it. If you start doing these things and they hurt, stop. If it hurts, don't do it. What I tell people, if I can get all the way out to here and it doesn't hurt, but if I go 5 more degrees it hurts, just stop. Stop where it doesn't hurt, even if all you can do is this little bit. And every day, I promise you, you'll get more. But yes, if it hurts, like ow, 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 you don't want to do that. That's only going to make the problem worse. And this is the problem I run into in 30-year-old guys who want to hunt fish, and they're carpenters or iron workers, and they got a shoulder that just hurts them, but they can still do it, and they just fight through it all summer long. They create big problems for themselves by fighting through the pain, right? It's not the women, it's only the guys. The women are smart, they're hurting, they figure it out, they come in, they get taken care of. But the men, we're not that bright. You know, God only took a half a day to figure out that we needed help, right? It's not good for man to be alone. It's pretty obvious right off the bat, you know. So, well, thank you again for your time. Like I said, I'll stick around for a few minutes. If you guys want to ask any questions one-on-one with me, that'd be great.